Good evening, everyone, and thank you for joining us today for this webinar on ex-vivo lung perfusion, state-of-the-art and perspective. My name is Mario Nosotti. I'm a surgeon, a transplant surgeon at the University of Milan, and I will moderate this webinar together with Professor Massimo Boffini. Massimo is a cardiothoracic surgeon working at the University of Torino. Massimo.
Thank you, Mario, for the introduction. This webinar is part of a rich program of activities that we have organized in preparation to the ESO 2021 Congress, which will take place online and in person from August the 29th to September the 1st in Milan. This session today will be focused on the opportunities offered by the EVLP. And as you will see very shortly, we have invited international speakers to share their knowledge.
Sure. This webinar is the first of many activities organized around the most exciting topic in transplantation machine perfusion. For this edition of the Congress, ESO has prepared a whole machine perfusion track, which will compose from series of webinars prior to the Congress, as well as multiple sessions delivered during the Congress here in Milan, together with Machine Perfusion Web Lab. We are happy to be opening this series with the subject of lung machine perfusion, and I believe are quite ready to start.
Yes,
Massimo?
Yes, we are. As you can see, we have an amazing list of speakers. So before I introduce our first speaker, I would like to encourage everyone to submit questions using Q&A button in your Zoom screen. And after we heard from all the speakers, we will have a short Q&A sessions with everyone. Without any further ado, I would like to introduce Professor Clemens Aigner from Essen, Germany. He is professor of thoracic surgery and he has a huge experience on lung transplantation and on EVLP. He will talk about organization of clinical EVLP service. Clemens, please.
Thank you for the kind introduction. I'm going to talk about how a clinical EVLP service can be organized and what prerequisites should be considered before initiating an EVLP program. I have no conflict of interests to declare. So what are the most important issues if you consider starting up an EVLP program now? I think the first question you have to pose yourself is what sort of transplant program should the EVLP program be based in? An important thing to consider in this case is the annual caseload of the program, the local donor organ availability, and the current average recipient waiting time in your setting. Based on these considerations, you can calculate an anticipated number of potential ex vivo lung perfusions you might perform in the setting of lung transplantation. So apart from the annual caseload and the local donor organ availability, the willingness to accept marginal donor lungs in the current situation of the program is certainly an important issue. And based on your average recipient waiting time and considerations of these factors, you really have to identify your need. Do you need an EVLP program and what should be the purpose of your EVLP program? So what are the potential purposes of running an EVLP program? The most important one is certainly an increased utilization of marginal donor organs. It might be the use of DCD lungs. It might be to simplify the logistic of transplantation, or last but not least, to initiate a research program. And I want to go a little more in the details of these topics. Ex vivo lung perfusion is certainly one of the most prominent recent opportunities that has evolved to increase donor organ utilization amongst the available donor organs. What can be achieved has been nicely demonstrated by this paper from the Toronto group, which was reported 2 years ago, where they reported an increased annual lung transplant volume of 70% compared to before the initiation of EVLP, which has now in the meantime doubled since the initiation of EVLP. And this experience has been repeated by several other centers who could tremendously increase their annual caseload by using ex-vivo lung perfusion as an additional method. The question whether to use EVLP as standard preservation method instead of cold static preservation has been addressed by 2 large prospective randomized trials. One done back in Vienna, which was published a couple of years ago. And the second one was the INSPIRE trial. And when randomizing between cold static preservation and ex-vivo lung perfusion, actually the parameters between the recipients were comparable, more or less, in both groups. And so the conclusion is that EVLP is certainly not the method to preserve every standard donor lung. Even though results are comparable, we know that an extension of the total ischemic time is possible in a safe way, but it rather acts as an additional evaluation tool, which allows to identify and exclude lungs with functional impairments and has the possibility to simplify the logistics. The second trial, the INSPIRE trial, more or less with a little bit differences in the endpoints, demonstrated comparable results and long-term outcome in that aspect. We're going to have an additional talk particularly focused on the use of DCD, so I won't go into details of that, but this is merely a case to demonstrate in an uncontrolled DCD how ex-vivo lung perfusion can overcome the possibility or can help with the possibility to re-evaluate the donor organ, and in such a situation to clarify the necessary logistics to bring in the recipient with an excellent outcome. Last but not least, what I mentioned, one of the potential focuses of an EVLP program can also be a strong focus on research. And if you look up in PubMed, you have now more than 1,000 publications focused on ex-vivo lung perfusion with a sharp increase in the last years. This is one of the papers we recently published in extending EVLP also beyond the field of transplantation. And there are several focus themes where research focuses on now and where the applications of EVLP are further expanded. So beyond the objectives of the EVLP program, of course, you have to clarify the resources and the facilities you have. Team, equipment, OR capacities, perfusion room costs, all these are really important issues that need to be considered in an EVLP program. EVLP is certainly not a self-running event, but it's something which is labor-intensive, which requires a lot of human resources to initiate and also to run. The core team, certainly in most of the settings, will be the lung transplant surgeons, together with perfusionists who are familiar of the ex-vivo perfusion systems in several settings and can also in daily practice provide the necessary know-how to run the machines. And of course, not in every setting, you have motivated anesthetists like Arne, who is going to give the next presentation. But it's, of course, very beneficial if you have a motivated anesthetist and also potentially a pulmonologist who is interested in EVLP and can further extend the spectrum of applications and the benefit you gain from an EVLP program. in most of the settings, if you're not doing 200 transplants a year with half of them from EVLP, EVLP will be rather an infrequent event which you are not doing on a daily basis. So it's very important to become familiar with the method, with a sufficient caseload, and with a structured training where you really know what to do, when to do, and how to do before embarking on an EVLP program. There are several devices available in the meantime. Some of them still shown here, still in development. And based on the devices, different applications might be used. There are transportable systems, there are static systems, and with differences in the perfusion, which the next talk is going to focus about, different details in application might be considered. So this is one of the crucial decisions to take, which system you want to work with and you want to get familiar with. I'm not going into the details of the perfusion methods. This is covered by the next talk. But one crucial logistic issue you need to clarify is also where to do the EVLPs. Particularly if it's a small program, if you're going to start up, the most likely setting will be that it is done in an operating theater. But you have to be clear that actually for the duration of EVLP and also for waiting for the lung until it comes in, an OR will be blocked for routine patient treatment. So this is something you have to consider. And if the caseload is anticipated to be more, it's very beneficial to invest into organizing separate perfusion rooms, or potentially in collaboration with the other clinical disciplines doing solid organ transplant, organized perfusion rooms for several organs together, which is very meaningful. You have to be aware that EVLP is cost intense. This is a published calculation from the Develop UK trial, just as an example. Of course, the exact costs vary a bit country-wise and from setting to setting, but it's clear that the benefits you get from EVLP are associated with a certain investment at the beginning and also ongoing during the use of EVLP. This is a cost-intense treatment. And the reimbursement aspects are too broad to cover here extensively, but they vary from country to country and sometimes even from local setting to local setting. And this is something that has to be clarified in advance and has to be well taken into account how EVLP programs can be reimbursed. So in summary, you can see there are several aspects to consider, and setting up an EVLP program only makes sense if you really do it as a program, if you want to go for a sufficient caseload, and it's certainly not something you should embark on if you just intend to do a single case or every now and then. Thank you very much for your attention.
Thank you, Clemens. You show us, you touch many issues, very important, and you show us it's not easy to build up a program for EVLP. And now I encourage everyone to ask questions through the Q&A, so we can take the question at the end of the session. So then our next speaker, I would like to introduce Arne Neyrinck from Leuven, Belgium. He is specialized in donor organ management and transplantation anesthesia. His research focuses on ex-vivo lung perfusion and lung transplantation and a complex problem related to ischemia perfusion injury. He's an expert on the donation of the circulation death donor and normothermic regional perfusion. Today, Arne will speak on the optimal protocol for EVLP. Please, Arne, start.
Thank you, Mario, for this kind introduction. Thank you, Clemens, for setting the scene on ex-vivo lung perfusion. So I will try to guide you a little bit more in detail about the different protocols, the main different protocols that are in use today for all different purposes. I have nothing to declare for my presentation, and I would like to dive immediately into the pieces of the puzzle. To understand really the protocols behind EVLP, I just would like to take you to the basics of EVLP. It's a very simple system. It consists of a closed circuit. You see here a closed circuit where the lung is mounted in the chamber, and a perfusate is circulated in this closed system using a pump. It passes a gas exchanger to the oxygenated perfusate in most cases, and then at some indications, filters are added. It can be leukocyte filters, cytokine adsorbents, it can be dialysis filters, and so on. Also, in the meantime, lungs are ventilated. They are ventilated with a ventilator, and this allows us to have a very good assessment of the graft done at 37 degrees at normothermia. This is very important. So what can we do then? We can try to measure everything, quite everything on our ex-vivo lung perfusion system, including all the pressures, the flows, blood gases, and take all kinds of different serum samples. We can measure ventilatory parameters, we can take lavage fluid, and many reports has also embarked on different imaging techniques, CT scan and chest X-rays of the lung isolated in the box. And this allows us, of course, to make clear decisions or try to make clear decisions on the graft function, which is, of course, a very important aspect in EVLP, how to assess the lung when you are performing ex-vivo lung perfusion. So it all starts with a functional assessment, looking at the differences in PO2, the PF ratio, compliance, driving pressure, the weight of the lung, even the perfusate loss. So the level of perfusate is a very easy marker to measure quality of the lung. And never forget macroscopy. Macroscopy is, even in the time of all the technologies, very important to assess lung quality. But we have moved forward to all kinds of biological assessment tools using these serum samples. We can do biochemical analysis. Metabolomics has been a very innovative approach recently, inflammatory markers, gene expressive profiles. And we all try to model this into predictive models for early outcome and acceptance of grafts after EVLP. So this is really the scene where you're working in, and it's a very rapid evolving scene at the center of ex-vivo lung perfusion. So my task is to guide you a little bit through the different protocols. And actually, it's a very simple task because there are not many different protocols that have been published or are used in clinical practice. Of course, many modifications exist in individual centers, but I would like to take you through the main concepts of the three major protocols that you will find into the experience of all different centers. And it's called the Toronto Protocol, Lund Protocol, and OCS Protocol. What are the differences in these protocols? Well, the differences are related to the flow through the lung that are ranging from 40% cardiac output towards 100% of cardiac output. Flows and the pulmonary artery pressure are limited. The Toronto Protocol uses a closed atrium system. All the others use an open system. And the big difference is also the use of the perfusate. Toronto protocols will use steen solution alone. Lund protocols will mix the steen solution with packet red blood cells up to hematocrits of 10–15%. And the OCS protocol uses OCS solution, which is actually a low potassium dextran solution. It's very similar to Perfadex, which is probably much more well-known among transplant surgeons, but added with some glucose and also mixed with red blood cells. The timing or the perfusion period differs from 4 to 6 hours, 2 hours to the whole preservation interval. And we have a very protective ventilatory protocol in all the protocols that is very comparable with low tidal volumes, PEEP, and also FiO2 might differ between 12% and 50% in the different protocols. But let's go to a little bit more in detail. So this slide you have already seen. These are commercial devices that can be used for the different protocols, and some protocols can be performed on different devices. But as you have heard from Clemens, there is a big innovative incentive for companies to come up with more devices in the future. So if you look at the protocol, you really have to understand why do you want to use ex-vivo lung perfusion. And the main applications today are still assessment of grafts and preservation of grafts. And we will hear later a little bit more about active reconditioning and probably long-term effects. But actually the big advantage of lungs on EVLP is, and which I refer to oftenly, is the lungs are awake and at work. And this is what you have to take into mind, into consideration when you look into the protocols. This is a very busy slide. I will not go into detail, but this is the major protocols or the major studies that have used the different protocols for different purposes. You have already heard about the purpose of recovery of organs, utilization rate of organs, and this is actually the main purpose or the main application used in literature, ranging from standard lungs to more extended donor lungs, and with some clear indications which lung to accept and not to accept. All these acceptance tools are based on the stability of the physiological trends in time, not declining more than 15 to 20%, and somewhere a clear cutoff value of the PF ratio. And we have seen mixed results, and especially results that are inferior, similar, or slightly better than the other control lungs. But we still have to learn which lung we have to put on EVLP for which purpose. The timing is probably sometimes confusing when you go into detail into these different studies. And I would like to summarize a little bit the timing in this slide. So the timing refers to at what time point you have to put the lung on EVLP during the donor and the receptor reperfusion phase. So when you look at preservation purposes, you probably would like to aim to put the lung as long as possible on the machine perfusion, and reports with the OCS system have been from 4 hours up to 18 hours in case reports. But so this is actually the concept of preserving lungs. Most reports actually refer to intermittent reperfusion on ex-vivo lung perfusion by a period ranging from 3 to 5 hours for really reassessment of the lungs. And this is anticipated by a cold perfusion period, maximum probably 9 hours, and also there is a cold perfusion afterwards, and there is some evidence that we should not prolong it too long, 5 hours, but 10 hours have been reported in experimental setting. But overall, if you look at the lungs from experimental designs, we see that ex-vivo lung perfusion can be performed up to 24 hours in an acceptable way, with total ischemic times up to more than 36 hours. So this is a large potential. But what we do not know is, like what I have illustrated down here, should we go for intermittent ex-vivo lung perfusion? This is something probably we should still embark on or explore in the future to see what is the real potential of ex-vivo lung perfusion. And then the ventilation. Ventilation is very basic in ex-vivo lung perfusion because all major clinical protocols use a volume-controlled ventilation with a low tidal volume between 5 to 7 milliliters per kilogram predicted body weight. But however, ventilation is very crucial because we can do a lot of damage, and we do not really understand the impact of mechanical ventilation in an isolated lung without a chest surrounding the graft. So new strategies are being explored in experimental settings, referring to continuous airway pressure or airway pressure release ventilation, flow-controlled ventilation with constant inspiratory flows, and also negative pressure ventilation by making the surroundings of the lung negative might have a benefit to reduce the ventilation-induced lung injury. Because we have been focused mainly on low tidal volumes, but we have shifted away from the concept of only low tidal volumes, and we now understand better why ventilation might injure lungs, and we like to refer more to concepts of driving pressure, of strain of the lungs, rather than tidal volume alone. And this is probably an area where we have to innovate a little bit more when looking at ex-vivo lung perfusion. And then the magic. The magic is the perfusit, I think. The perfusit is it's a very important concept when you look at ex-vivo lung perfusion. And what can you learn from the perfusit? Well, in all the protocols I have illustrated, some protocols will use red blood cells, packet red blood cells. And of course, it is important to respect the transfusion rules about ABO compatibility in these protocols. Just to remind you that not all blood groups can go with all lungs. So this is also value for ex-vivo lung perfusion. But then we have this mysterious Steen solution. Steen solution actually is just also a dextran solution, low potassium dextran solution mixed with albumin at a certain concentration with anorganic buffered salt solution. And it's a very buffered solution, and it has been proven that it can really have an antioxidant effect. But however, new preservation solutions are explored using custodiol or even perfluorocarbons added to the perfusion. But steam solution is really in the center of most of the protocols. And then the additives. Additives are probably also very important, and we still have to learn a lot about the additives. What is very consistent is at the addition of salmeterol, heparin, antibiotics, but what we start to learn now is the metabolism of the lung. We have seen in recent reports that metabolic balance is a very important process, and we probably don't give enough food to the lung. We see a lot of catabolism, and we should probably add more nutrients and also look to removal of byproducts in a certain way, perhaps by dialysis or other filters. So optimization is needed there by functional and biological assessments. And I would like to refer to this very innovative and disruptive paper where they have connected lungs, human lungs, 24 hours to a living animal, a living pig, where they have actually provided the removal by a whole body and the whole blood addition of more nutrients to the lung, with good results in the recovery of the graft over time. Cellular or acellular? Well, what is the best solution there? Should we add red blood cells or should we not add red blood cells? Well, few comparisons have been made, and you see here that steam in porcine models that steam solution is comparable to steam solution with red blood cells. Other reports have compared OCS plus red blood cells, steam versus steam solution versus whole blood, where actually whole blood is a very good solution for ex-vivo lung perfusion. And also we have a recent comparison between the Lund and Toronto protocols, where we saw a little bit more edema formation in Toronto protocols. But this is all experimental in animal models. Last but not least, what do we know or should we know about this perfusion of this graft in a box? Well, we have also learned that perfusion of a graft in a box is a very unifocal approach to lung preservation. And we have learned a lot about prone positioning in the last year. And actually, we have also reported that proning the lungs and ex-vivo lung perfusion might even differ or alter the distribution of pulmonary edema. And we should not forget that it's a very complex physiology, lung physiology. It interacts with alveolar pressures, with perfusion pressures, and is not surrounded by a chest. So we really have to reinvent physiology, and it's not a simple comparison of physiology in a box to physiology in vivo. We also have seen in other organ perfusion systems of other organs that there is a whole area of lowering again the temperatures of the perfusit, and probably there's also a potential to really relook or reassess the optimal temperature of ex-vivo lung perfusion. So in conclusion, be very careful for which purpose you will use ex-vivo lung perfusion when looking at the protocol. EVLP parameters are very simple, but again, are not very simple because they do not always reflect physiology. We have a lot of protocols that are difficult to compare. The technology can definitely be improved, and probably the better way to go is to look at a more personalized lung medicine approach, which protocol is perfect for which lung. Thank you for your attention.
Thank you, Arne, for your complete overview of EVLP technologies. Your presentations are always amazing, and we have learned a lot. Our next speaker tonight is Professor Ilhan Inci from Zurich, Switzerland. He is a full professor of thoracic surgery at the University of Zurich, and he will speak about reconditioning lung with EVLP. Ilhan, please.
The topic is the reconditioning of lung with EVLP, but I cannot move the slides. I don't know, maybe like this. Okay, I have nothing to declare. Okay, potentially life-saving donor organs are discarded every day. Why? One, because inability to effectively assess organ viability, and two, and the second reason is poor function as a result of injury or disease. The possibility of assessing, preserving, and reconditioning of these organs ex vivo prior to transplantation could dramatically increase the number of available organs. Ex vivo lung perfusion, EVLP, is a technology for the assessment, preservation, and optimization of lung donors prior to transplantation. This might lead to recovery of the organ which is initially unsuitable for transplantation. Among other solid organs, the lungs are unique because of its dual access system. We can use either bronchial or vascular route for direct pharmacological intervention. In theory, EVLP should allow the administration of most effective medications based on specific causes of lung injury while avoiding toxicity, systemic toxicity. Different drugs according to the type of injury, even a combination can be administered at high doses and repeated intervals. Antibacterial, antiviral to treat infection, cytokine inhibitors, bronchodilators, fibrinolytic agents, high osmotic agents to remove interstitial edema can be used for the recovery of the lung donor. It has been demonstrated that broad-spectrum antibiotic therapy administered during EVLP reduced the bacterial burden, reduced endotoxin levels, and improved lung function of donor lungs clinically declined due to infection. The beneficial effects of mesenchymal cells have been confirmed in lungs on EVLP with various types of lung injury. Tracheal instillation of allogenic human mesenchymal stem cells restored alveolar fluid clearance, reduced inflammation, and exerted antimicrobial activity in ex-vivo perfused human lungs injured by Escherichia coli endotoxin. Then the administration of human mesenchymal stem cells through the pulmonary artery during EVLP significantly reduced inflammatory activity and apoptotic cell death in pig donor lungs. Hepatocyte growth factor released from human mesenchymal stem cells could account for their anti-inflammatory and anti-apoptotic efficacy during EVLP. Multipotent adult progenital cells, MAPC, are another promising strategy for stem cell therapy and led to remarkable anti-inflammatory effect in lung when utilized during EVLP. The Leuven group published this work in 2017. They observed a reduction in pro-inflammatory cytokines and neutrophils in bronchoalveolar lavage in the MAPC group without difference in lung physiology. They speculated that this effect on the innate immune system might play an important role in critically modifying the process of primary graft dysfunction after lung transplantation. In our center, based on our extensive research, we reconditioned a donor lung affected with massive pulmonary emboli in EVLP system with urokinase and successfully transplanted this lung into a cystic fibrosis patient. During EVLP, as you see, pulmonary vascular resistance went down and compliance went up, and this patient is alive with a good lung function. At the same time, Toronto group also published a case report with the use of a thrombolytic agent. They used alteplase 20 milligram to recondition the donor lung. This patient was also successfully transplanted. When we started with EVLP experiments, surfactant was also one of the agents that we wanted to test to recondition the injured lung. In this study, we investigated the role of surfactant during EVLP in reconditioning pig donor lungs that were injured by gastric aspiration. Intrabronchial surfactant lavage resulted in improved graft function and decrease in inflammatory cytokines like IL-8 in bronchoalveolar lavage compared to the control group. One limitation in that study was we did not transplant these lungs following EVLP. We also proved the beneficial effect of intrabronchial surfactant installation in peak DCD model of EVLP and transplantation, which led to reduced inflammation and good post-transplant lung function. Lung lavage followed by surfactant replacement during EVLP reduced inflammatory mediators and prevented hydrolysis of phosphatidylcholine, which contributed to the superior post-transplant function in donor lungs with aspiration injury. Similar to drug therapy, gene therapy during EVLP is also a feasible targeted approach to recondition the lungs. In a series of 5 human donor lungs determined to be unsuitable for transplantation, Toronto group subjected these lungs to 12 hours of EVLP and treated them by transbronchial therapy with the gene coding for anti-inflammatory cytokine IL-10. Human adenovirus IL-10 gene transfer significantly improved oxygenation and reduced pulmonary resistance. Japanese group reported on the use of an adsorbent membrane in the circuit to suppress the levels of anti-inflammatory cytokines during 12 hours of EVLP. Interleukin-8 and tumor necrosis factor alpha levels were significantly lower in the membrane group compared to control group. In this study, our group tested the safety and efficacy of continuous cytokine removal in prolonged pink EVLP model. We observed remarkable decrease in inflammatory cytokines such as IL-6 and IL-8 in this study. As a second step, we hypothesized that perfusate adsorption during EVLP would recondition the allograft to ischemia perfusion injury after lung transplantation. The perfusate concentrations of cytokines were markedly reduced with the adsorber, resulting in improved EVLP physiology and biochemistry during 6 hours of reperfusion period. Graft oxygenation and dynamic compliance were continued to be superior in the adsorber group at the end of transplantation, accompanied by a markedly decreased local inflammatory response. Medical gas therapy via ventilator during EVLP is another promising strategy to recondition the injured lungs. In this DCD pig model, hydrogen gas inhalation during EVLP improved the function of lungs. However, these lungs were not transplanted to test the post-transplant function. Inactivation of HCV-positive donor lung using light-based therapies during EVLP is also a novel strategy. In this study, during 9 hours of EVLP, virus load was deactivated. In addition, following their research, Toronto group conducted a clinical study, and donor organ treatment with this perfusate irradiation during EVLP significantly decreased HCV viral loads within the first 7 days after transplantation. Early and intermediate clinical outcomes were not significantly different between the patients receiving HCV positive and HCV negative donor lungs. Several animal studies or several animal models of lung injury have demonstrated the anti-inflammatory effects of perfluorocarbon-based oxygen carriers. In this study, we hypothesized that perfluorocarbon-based oxygen carrier nanoemulsion, a novel reconditioning strategy, instilled during EVLP would improve graft function. Although this strategy did not significantly affect the EVLP physiology, metabolic markers of donor quality such as lactate production, glucose consumption, neutrophil infiltration, and preservation of mitochondrial function tested with fluorine mononucleotide assay were better in the oxygen carrier group. After transplantation, perfluorocarbon-based oxygen carrier group resulted in a better graft function, and transmission electron microscopy showed better tissue preservation, cellular viability, and improved gas transport. So in conclusion, EVLP is a useful method to improve and reassess the function of marginal donor lungs. EVLP increases the safe use of questionable lungs. Moreover, with this technique, we have the ability for targeted treatment strategies to treat injured, otherwise unacceptable donor lungs. Thank you for your attention.
Thank you, Ilhan. Thank you for this overview of the several procedures that we can have to EVLP to make this lung better. Now, I encourage everyone to ask questions through the Q&A section in the Zoom, and so we can take them at the end of the session. Our last speaker, but definitely not the least, is Professor Frank Dovidio from New York. He is an associate professor of surgery at Columbia University Medical Center and surgical director of the lung transplant and ex-vivo lung perfusion program. Dr. Dovidio has published extensively on the subject of transplantation, ex-vivo lung perfusion, and he is a dear friend. So his talk today is about EVLP for lungs from DCD donation. Why, when, how? Frank, please, the floor is yours.
Thank you, Mario and Massimo, for inviting me to participate in the webinar today. I have a disclosure. I have some research support from Ex-vivo perfusion. And I'll start by describing the 4 categories that we are challenged with when we talk about DCD donation. In particular, there are 2 uncontrolled and 2 controlled. The first and second category are uncontrolled. First category are donors found dead either outside the hospital or inside the hospital, and these have not been submitted to any resuscitation. Then we have category 2, which are uncontrolled witness cardiac arrest with a unsuccessful resuscitation, whether in hospital or outside the hospital. And the 2 controlled categories, 3 and 4, where 3 is the most commonly utilized today with withdrawal of life-sustaining therapy with a planned expected cardiac arrest. And the uncontrolled controlled is the occasional scenario where a brain dead donor is identified and planned for recovery, although arrests prior to that being implemented. A historical note, the first lung transplant in 1963 was actually from an uncontrolled DCD donor that Dr. John Hardy brought forward and initiated the modern transplant era. Of curiosity, 40 years later, Professor Stig Steen did the first EVLP transplant in 2001 from an uncontrolled DCD donor, implementing his lung in a box and opening up the future application of EVLP as we are today talking about. Well, EVLP in the uncontrolled scenario offers obvious opportunities to extend the assessment, navigate logistics, confirming donation, screening the serology, bringing recipients to the hospital, but most importantly, assessing the quality of the organ. Having said that, in the phase where EVLP was not available, the group in Spain had challenged these donors successfully, although declaring a quite high primary graft dysfunction rate ranging up to 38%. On the other hand, the utilization of EVLP in uncontrolled has been reported recently from the group in Milan, led by Dr. Mario Nosotti, where they have shown how EVLP can extensively be implemented to extend the lung preservation, reaching 33 hours on the first lung and 36 on the second, with a successful outcome. In the context of controlled DCD, well, clinicians and surgeons have been challenging these donors much before EVLP was available and showing equivalent results compared to brain-dead donors. This has been extensively reported in the ICHLT registry, as well as meta-analysis of the literature and single-center reports. Recently, in the ICHLT meeting last year, analysis of the transplants performed in the UNOS database from 2015 to 2017 showed 5,866 patients were transplanted, and only 4% of them were from DCD. And of those that received a transplant from a DCD donor, 14% underwent EVLP. There was no difference in the characteristics of the patients from DCD donors that underwent EVLP or not, and they both showed equivalent results. Of interest, the centers performing DCDs utilize EVLP with great variability, ranging from 0% to 54%. What is interesting in this presentation is how only 4% of the experience was from DCD donors. And so EVLP has a potential to increase the percentage of transplantation from the DCD donors and potentially bring, at least in North America, the field forward in trying to match results and application as reported in other countries, and in particular in the paper presented by the group led by John Dark, where DCD lung transplants now in the UK account for about 21% of the transplant activity, therefore increasing significantly the pool of donors. And along these lines, EVLP in the context of controlled DCD donation may help navigate the concerns behind extended agonal time. As a group in Toronto has been advocating, EVLP can provide the comfort of confirming the quality of lung to be used for transplantation when the agonal time is being extended from 60 minutes to 180 minutes, so going from 1 hour to 3 hours. And more recently and interestingly, ex-vivo perfusion, and in particular, ex-vivo heart-lung perfusion, will provide the premises for a utilization of the assessment from DCD donors of the heart-lung block for the small niche of patients that today need a heart-lung transplantation. Now, as previously shown by my colleagues, the EVLP, as well as for any type of lung assessment in the donor in DCD donation context, can be performed by the different systems, whether in-house or the industry provided systems. None of them have been shown superior one to the other. It's also true that there's not been a head-to-head study showing what to investigate whether one system would be preferred. Where should the EVLP be done? And the vast majority, it's within lung transplant centers. There are OPO organizations that have acquired the systems and provided the premises for the gravitating lung transplant centers of their organization to utilize the machine in their hub. Lastly, there is industry interested in providing services to lung transplant centers. The important is that the organs be allocated fairly and resources be allocated in a fair fashion, as well as that the research and development be brought forward. In my opinion, the opportunity of industry is of interest, providing the service. I'm still somewhat skeptical that at this stage, the surgeons and the physicians involved in ex-vivo lung perfusion should be distanced from the assessment, as many times the devil is in the details. Again, whether EVLP should be done by a technician or a clinician, I think today and going forward, as we have heard from the different speakers, it is a clinical act. And the whole goal is to assess the organs and ultimately treat them. So finally, when do we need EVLP in the DCD donation? Well, I think in the uncontrolled DCD donor, it's a mandatory step to assess the quality of the organ. In the controlled DCD donor, it is a center preference and based on experience. When non-comfortable and given the limited assessment of the organ that the DCD scenario offers, it is an important tool to be available to implement. To reassess the quality, and similarly, when your team is not experienced or inconsistent, based on residents, fellows, or rotating surgeons, or when your organ is being procured by some other center that you not have a good relationship with. Thank you.
Okay, thank you very much, Frank, for your excellent overview on EVLP and DCD donation, and thanks to all the speakers for their outstanding presentation. I want to invite all the attendees to submit some questions in the Q&A box available on your Zoom interface, and there is one question. The first question maybe for Clemens. What do you think EVLP equipment manufacturers need to do to encourage use of perfusion in smaller, lower volume transplant programs?
Yeah, thank you for the question. I think it's critical that a certain volume is maintained in order to achieve reasonable outcomes in the experience you need to deal with the judgment of the lung and with the decision whether to ultimately use the lung or not. I think structured training and exposure to a certain amount of cases is a very crucial part of it. If in a smaller program you're not exposed to the necessary amount, visiting a larger center where a critical caseload is done and getting exposure to really a couple of cases and finding out about the pitfalls and the small important details of EVLP is very important during the training period. And once you have got this experience, you can embark on a program even in smaller programs. The remote perfusion programs or industrial, like it's been propagated, are not really yet established. I would say this is something that can be considered, but the initial caseload is the crucial step, I think, in the beginning.
Okay. There is another question. Does EVLP improve lung transplant outcome? I think that Ilhan.
I mean, outcomes, there are a lot of reports, also from standard donors from Vienna. I mean, it has been shown that at least they are comparable. But what it gives us, it improves the number of donors. And as is shown, the Toronto group, they with the same donor pool, they increase their transplant activity 70%. And also in other programs, if they have medium programs or low volume, if they do 20 per year, and if they can do 3 or 4 with EVLP, then they increase 20%. So this is what is the success of this system. I mean, not outcomes are more or less the same, equal. But the major gain is that you catch the donors that otherwise you discard them, and you can increase with the same pool but more transplants.
Okay, thank you very much. There is another question for Arne, I think, regarding the assessment tools during EVLP. Is the assessment reliable and precise?
I think that's a very good question, and I think we have to be honest that this validation or this assessment is really not well validated, to be honest. So we have these trials, prospective trials, where they're looking at clear cutoff values, but I think it was clear from my presentation also that it's really difficult to understand what is a PO2 in a box reflected to a PO2 in vivo. So there are many factors influencing these parameters. So at this point, I would like to say it's not well validated, which does not mean that it's not important to look at. And we have built up some experience with specific variables. There are now models created where some of these physiological variables like compliance and PO2 are predictive of acceptance rates after EVLP, but it's a very slow process. And we should not forget, I think many of the colleagues have been too much focused on, we have to copy physiology. I think we have to understand ex vivo lung perfusion, but we don't necessarily have to copy physiology. So it's two different things. And I think we have to think out of the box, if I may say so, to how to understand these parameters. But we need more validation of these physiology parameters, for sure.
Yeah, and I would add also that it depends on the protocol that you use. I mean, if you use a cellular or a cellular perfusion, PO2 maybe is not so reliable in both the protocols. And I think that we have time for one more question for Frank. And you talk about the DCD donation and EVLP, and we know that the graft is exposed to several potential injuries during this process. How much is important the warm ischemic time, and how much and how long can we rely on the ventilation only to protect the graft?
So the ventilation only during, it's not clear to me the question. Can you, what are you trying to get at?
I mean, we rely on ventilation during DCD donation, right? And we believe that this is enough, and but we are not sure for how long can we rely on this strategy. And what is your experience?
I can tell you our experience. We've been doing the DCD donation without the EVLP. Of the cohort that was reported, we're one of the ones that have done 0. And that's because we've started DCD assessments prior to the EVLP. And we got comfortable. We also have a very experienced procurement team that has gone out on all these DCDs, and we've set up our protocol to assess, relying very much on the preclinical, pre-donation assessments and mandating CT scans, which ultimately now are always available, particularly after the COVID pandemia effect. So we've been extending also our agonal time. We were initially limiting at an hour and a half, and now we go along to whatever the hospitals allow us. And many centers mandate a 60 minutes, some will allow 90 minutes, some will go up to 120 minutes. And we haven't had any bad events or poor outcomes that we would shy away from the assessment so far. We've done one last week with 90 minutes and good outcomes. So the implementation of the EVLP and DCD in my mind is to comfort. To comfort your act, and also to allow you to be comfortable going out for these DCDs. ultimately the quality of the organ is assessed during the pre-donation scenario or moment, and during the intraoperative assessment is part of the key element in our hands. Our experience with EVLP has been that we've trained extensively before implementing it clinically. As Clemens was indicating, you want to keen all the knowledge and the details behind the EVLP procedure. And we use it as an armamentarium that we have, implementing as we think is needed, based on our comfort. And I think the centers should embrace the opportunity to have it so that they can use it as their comfort and their understanding of that specific donor is, whether it's brain dead or DCD.
Okay. Thank you very much.
Thank you, thank you. I'm very sorry, but I'm afraid I have to close the webinar because we are out of the time. So let me thank all the speakers for their very interesting session. And I would ask to the participant to answer to the poll that will soon appear on the screen. Exactly, you can see now. Please sign your preferred option. And I want to wait for a moment to see your results. And in the meantime, I want to remind that there are many other webinars on machine perfusion. So, okay, these are the results. Extremely useful for 48% of the attendee and useful for 48% of the attendee. Okay, so we are very happy for these results. And I invite all participants to explore the Congress program and register to the Congress in Milan. And I am waiting for you here in Milan. There are some exciting programs except on the machine perfusion. Thank you very much. Have a good night.
Thank you very much for participating to this webinar. And I remind you that the recording will be soon available on the ESOT platforms, YouTube channel, Transplant Live and Congress platform. I also hope to see you in person in Milan at the ESOT Congress at the end of summer. And I wish you a pleasant evening and keep safe. Goodbye.
Bye.